Good morning/afternoon, colleagues. I'd like to present a case that highlights the importance of maintaining a high index of suspicion for indirect carotid cavernous fistulas following seemingly trivial cranial trauma. Our patient is a 54-year-old woman who sustained a mild head trauma, blunt low-energy mechanism. She was evaluated in the emergency department, underwent standard workup, and was discharged after 48 hours neurologically intact, save for minor left periorbital pain, initially attributed to local soft tissue injury. This subtle complaint was the sentinel symptom of a Barrow type D indirect dural carotid cavernous fistula. This entity presents with an insidious onset and is frequently misdiagnosed as conjunctivitis, thyroid eye disease, or post-traumatic orbital contusion. Key teaching point is even after mild head trauma, periorbital pain, chemosis, or injected episcleral vessels should trigger dedicated vascular imaging. Untreated, the consequences, seroelevated IOP, progressive proptosis, cortical venous reflux, and intracranial hemorrhage, are entirely preventable with timely intervention. These photographs were taken approximately 8 hours after discharge, roughly 56 hours post-trauma. The family brought the patient back to the emergency room after noticing rapid clinical deterioration. What we see is immediately striking: bilateral conjunctival injection, left-sided chemosis, early proptosis most pronounced on the left, and, critically, arterialization of the episcleral veins. Those dilated, tortuous, corkscrew-shaped vessels are essentially pathognomonic for a carotid cavernous fistula. They reflect retrograde venous hypertension transmitted via the superior ophthalmic vein as it drains into the engorged cavernous sinus. Note the bilateral involvement. While unilateral presentation is more common, bilateral ocular signs occur in approximately 10–15% of CCFs and indicate intercavernous sinus communication or bilateral arterial supply, an important point that influences angiographic assessment. At this visit, ophthalmology confirmed elevated intraocular pressures bilaterally, consistent with impaired aqueous outflow secondary to episcleral venous hypertension. Dedicated cerebrovascular imaging was urgently arranged. The speed of this evolution, from a single complaint of periorbital pain to florid ocular venous hypertension within 8 hours, underlines that indirect CCFs, though traditionally labeled as low flow, can progress rapidly and should never be observed without a clear management plan. These DSA clips show the pre-treatment angiographic runs. I want to walk you through what each panel demonstrates and why it informed our treatment strategy. On the left panel, this is the arterial phase injection, demonstrating the external carotid contribution to the fistula resosondecis specifically. Dural branches including the middle meningeal artery and accessory meningeal artery opacifying the cavernous sinus during the arterial phase. This is consistent with Barrow type C or D morphology, confirming the indirect dural nature of the shunt. On the right panel, note the early opacification of the cavernous sinus during the arterial phase with retrograde filling of the superior ophthalmic vein. The angiographic hallmark of cavernous sinus venous hypertension. The absence of a direct ICA to cavernous sinus communication effectively rules out a high-flow Barrow type A direct fistula, which would require a fundamentally different treatment approach. The key question on every pre-treatment DSA in CCF is their cortical venous drainage. Retrograde filling toward cortical veins dramatically elevates hemorrhagic risk and mandates urgent same-session treatment. In this case, drainage was predominantly through the superior ophthalmic vein anteriorly and Wahasimutana, to a lesser degree, the inferior petrosal sinus inferiorly. No cortical venous drainage was identified, which allowed us to plan a semi-elective but prompt intervention. Finally, regarding Barrow classification, types B, C, and D are all dural CCFs distinguished by whether arterial supply comes exclusively from ICA dural branches delf of B, ECA branches delf of CE, or both delf of D. Type D is the most common and is what we see here. These 5 static angiographic frames provide the anatomical roadmap that guided treatment planning. Let me take you through the key observations. The multipedicle arterial supply is evident. We can identify contributions from the accessory meningeal artery, the artery of the foramen rotundum, the inferolateral trunk of the ICA, and likely meningohypophyseal branches, series a pattern entirely consistent with a type D dural CCF, and one that recapitulates the angioarchitecture seen in other intracranial dural arteriovenous fistulas. For procedural planning, 3 questions are paramount. First, Wallace-Thornton, what is the caliber and tortuosity of the feeding pedicles? This determines whether transarterial catheterization is feasible with current microcatheter technology and which pedicles offer the most direct access to the fistula nidus. Second, what is the dominant venous outflow route? The superior ophthalmic vein, hellular, when sufficiently enlarged, can serve as a transvenous access route, which was potentially available here as a backup. Third, hellular, is cortical venous drainage present? As noted, it was absent in this case. The dominant drainage here is through a markedly enlarged superior ophthalmic vein with secondary outflow via the pterygoid plexus and inferior petrosal sinus. The SOV caliber, combined with the degree of clinical venous hypertension, made transarterial Onyx-based embolization the primary strategy, with transvenous coiling as a contingency. One additional point, the bilateral carotid injections and external carotid runs should always be performed in full to identify all contributing pedicles, as incomplete embolization due to unrecognized supply is the primary cause of early fistula recurrence. These 3 fluoroscopic images document the intraoperative embolization sequence. I'll walk through the strategy and the rationale for each step. The left image shows selective microcatheter access to a dominant feeding pedicle with coil deployment. We used soft, detachable microcoils in the proximal portion of the high-flow arterial pedicles to reduce shunt volume and create scaffolding for liquid embolic penetration into the nidus. Coils alone are generally insufficient for dural CCF cure to monitor. Their role here was hemodynamic preparation. The center image demonstrates balloon-assisted Onyx injection. A non-detachable compliant balloon is inflated across the fistula zone, cellular in this case within the cavernous sinus compartment cellular, serving 3 purposes: preventing proximal Onyx reflux toward the ICA, allowing pressurized injection to drive the liquid embolic deeply into the fistula network, and protecting adjacent non-target structures. Onyx 18 was chosen for its non-adhesive, cohesive properties, which allow extended injection time and progressive cast formation through complex angioarchitecture. We used a dimethyl sulfoxide compatible microcatheter throughout. The right image shows the final Onyx cast confirming dense filling of the fistula's cavernous sinus compartment. The goal at this stage is not total obliteration of the cavernous sinus itself, but elimination of the pathological arteriovenous shunting confirmed angiographically on the post-treatment runs you will see next. In contemporary series, transarterial embolization with liquid embolics achieves angiographic cure in 90% of dural CCFs. Main procedural risks include cranial nerve injury from cavernous sinus packing, particularly CN3, IV, V1, and VI, non-target embolization, and recurrence due to collateral arterial recruitment. None of these complications occurred in this case. These post-embolization DSA runs confirm the angiographic result and represent the procedural endpoint. Left panel, the previously opacified cavernous sinus no longer fills during the arterial phase. Normal intracranial venous drainage is restored. There is no residual early venous opacification, no retrograde superior ophthalmic vein filling, and on pass and critically see no cortical venous drainage. This constitutes complete angiographic obliteration of the fistula. Right panel contralateral ICA injection shows no intercavernous filling, confirming bilateral supply has been eliminated. The full ECA runs likewise showed no residual shunting. The Onyx cast has effectively occluded all identified feeding pedicles. This endpoint, complete elimination of arteriovenous shunting with restored normal venous drainage pattern. Ceruleness is the gold standard definition of procedural success in CCF embolization and the benchmark against which we plan follow-up imaging. Clinically, the patient remained neurologically stable throughout the procedure. No new cranial nerve deficits were present at the end of the case. Importantly, clinical improvement was detectable within hours post-procedure. Reduction in chemosis and episcleral vascular engorgement was already visible in the recovery room, reflecting rapid decompression of superior ophthalmic vein hypertension once the arteriovenous shunt was eliminated. This early symptomatic response is one of the most gratifying aspects of CCF treatment and provides immediate reassurance to the patient and family. This is the 3-month clinical follow-up photograph, and I think it speaks for itself. Complete resolution of proptosis, chemosis, and episcleral vascular engorgement is evident bilaterally. The patient has returned to a fully normal clinical appearance. She reported resolution of all periorbital pain and the diplopia that had emerged during the symptomatic period. Intraocular pressures had normalized by the first outpatient visit, approximately 2 weeks post-procedure. This case consolidates several important teaching points for our practice. First, mild cranial trauma is a recognized, though often underestimated, etiology of indirect dural CCFs, likely through disruption of pre-existing subclinical dural arteriovenous microshunts or de novo fistula formation at sites of dural venous trauma. The mechanism is different from direct high-flow type A fistulas, which typically require significant skull base fracture. Second, the clinical course can be surprisingly dynamic. Cestial florid ocular venous hypertension appeared within hours of discharge, emphasizing that these patients need an explicit return precaution plan and ophthalmologic coordination. Third, modern transarterial embolization using coil scaffolding combined with Onyx 18 and balloon assistance provides durable anatomic cure with rapid symptom reversal and excellent functional outcomes. For follow-up protocol, I recommend clinical review at 6 weeks with dedicated MR angiography or cone beam CT venography at 3 and 6 months post-treatment for asymptomatic patients. Conventional DSA should be reserved for those with recurrent symptoms, cerulean flow new proptosis, chemosis or pulsatile tinnitus, cerulean flow or indeterminate cross-sectional findings, mod lalawanhuilahantoameta or indeterminate cross-sectional findings. In this patient, the 3-month MRA confirmed no residual shunting and she was discharged from neurovascular follow-up. Thank you for your attention. I am happy to take any questions.